Thank you, Dr. Patterson, and welcome to this session, which is looking at cardiac amyloidosis. My name is Gary Small. I'm the head of the cardiac oncology clinic here at the Ottawa Heart Institute. I'm an imaging cardiologist with interest in nuke PET and cardiac CT. I'm joined by my co-moderator, who is Dr. Nowell. Dr. Fine is a leader in cardiac amyloidosis in Canada. He's based in Calgary. Good afternoon, Dr. Fine. Are you online, sir? Whilst Nowell joins us, I'm just going... Oh, so Nowell's just having a couple of technical issues. Whilst Dr. Fine's... whilst we're working those out with Dr. Fine, we have a very an excellent timetable for you this afternoon. We have some very, very good speakers. We have two cases by fellows, one from Calgary and one from Ottawa, and also two excellent speakers from the US, Dr. Jonathan Wall and Kristen Sue. And I'm sure this is going to be a fascinating session. What I might do in the interest of time is see if we can introduce our first speaker. Dr. Toma, are you online, sir? Dr. Toma Mustafa? I don't see his name here in the room. We've had a few IT issues today, and I do apologize for that. So I don't see Dr. Toma connected yet. What about Dr. De Silva? Is Dr. De Silva online? So Dr. De Silva.
Yes, I am.
So yeah. What we could do, if you like, is just switch up the schedule a bit, just in terms of the interests of time, and start with your case, if that would be acceptable.
Sure.
So what I'll do is I'll introduce you, and then if you wish to, you can then take your screen and share your screen with us. And take it away from there, okay?
Okay.
So actually, Dr. Fine might just be on. Here we are. Somebody just be off the line. So without further ado, let me introduce Dr. De Silva whilst we struggle away with RT issues. So Dr. De Silva is originally a board-certified cardiologist from Brazil. He completed his medical school and cardiology and fellowship in echocardiography in Sao Paulo in Brazil, and where he worked for several years. He came to Canada and has been pursuing a fellowship in rare diseases with us here in Ottawa. And he's also previously performed, he's also actually doing cardiac imaging with us as well. Edgar's been a real asset to our rare diseases program, and we're wishing him well in his future career. And we're very grateful for his time today to present this current talk. Thanks, Edgar.
Thank you, Dr. Small. And thank you for inviting me to this session. I'm going to present a case in cardiac amyloidosis. So I don't have any disclosures. I forgot to ask, are you guys able to see my slides?
Yes.
Okay. So the case is of a 64-year-old gentleman from Belarus that is a retired factory worker. He was diagnosed with a non-ischemic cardiomyopathy in 2019 when he had an episode of rapid atrial fibrillation. And he had also NYHA class 2. Past medical history, he had multiple cardiovascular risk factors, so hypertension, dyslipidemia, type 2 diabetes, and then AFib, and then he was an ex-smoker. He had also a history of bilateral carpal tunnel syndrome with surgery done in 2006. And later on, he was diagnosed with MGUS in 2022. And no significant past medical history regarding cardiac amyloidosis. In 2017, because of an episode of NSTEMI, he had a left heart cath that showed no significant coronary obstructions and normal ventriculogram. And in 2019, after the episode of atrial fibrillation, he was cardioverted at that time, and then his baseline ECG was showed sinus bradycardia, first degree AV block, left axis deviation, and the low voltage QRS. He had an echo in 2019 to assess his cardiac function that showed mildly reduced LVEF with mild concentric LVH. He had normal RV function, and he had an abnormal pattern of strain, but wasn't flagged as possible amyloidosis at that time. And he had a small area of hypokinesis in the basal inferior wall. But however, because of the atrial fibrillation, he had severe left LA enlargement and moderate RA enlargement. Again, in 2019, he was assessed for coronary artery disease with a CCTA, and it showed no significant obstruction. In a clinical assessment in 2020, they ordered a new echocardiogram and showed reduced EF to 40%, mildly dilated LV, and severe concentric hypertrophy. RV was moderately enlarged with ventricular systolic function on the lower end. And he had, again, severe bilateral enlargement. A Holter showed that he was, most of the time, it was 9.9% of the time in atrial fibrillation. And he had another assessment in 2022 for coronary artery disease with a percent in SPECT that didn't show any ischemia. Then on this assessment in 2022, his echo showed, again, LVH, abnormal GLS pattern, now flagged as possible cardiac amyloidosis, and then subsequent investigation for cardiac amyloidosis had started. So biomarkers were ordered, electrophoresis, he had a fat pad biopsy that came back negative, and then in 2022 he was diagnosed with MGUS. And this is here just a follow-up, like a table showing the echo abnormalities that he had. He initially in 2019 had EF of 49, and by 2022-23 his EF dropped, his wall thickness increased, and his GLS was stable. So he had the first cardiac MRI in December 2022 that showed diffuse transmural LGE with increased T1 and ECV values. The PYP done a month later was strongly positive for TTR cardiac amyloidosis with heart contralateral rate of 1.85, and he had grade 3 uptake. So in January of 2023, he was finally diagnosed with cardiac ATTR. He was offered genetic testing, which he agreed to pursue. Initially came as VUS, but then was reinterpreted in 2024 as a likely pathogenic variant. He was on this list of medication, including beta blocker, SGLT2, Lasix, ACE inhibitor, and anticoagulation. He was started on tafamidis in April 2023. At that time, he was assessed by neurology as well, that detected hand numbness, and his nerve conduction study showed possible ulnar nerve neuropathy. In 2024, he was reassessed by neurology that showed that his neurological symptoms and abnormalities were stable. He had a repeat cardiac MRI in 2023, and this is the images from the cardiac MRI I would like to show, and another one in 2025. So his cardiac MRI in progression of markers showed that his EF improved with treatment. His wall thickness was stable, but his T1 values and ECV values were increasing over time. So from 2023 to 2025. Clinically, he was stable, although from 2023 to 2025, he mentioned that he needed to take his Lasix more frequently. His BNP was stable in the 1,500 to 1,600. Because of this clinical presentation, and also because of the markers in the cardiac MRI and BAP still elevated, he was offered a switch treatment to vutrisiran because it seems like he wasn't controlled or stabilized with tafamidis. And he agreed, and because he had neuropathy associated, so it was approved for vutrisiran. So he started vutrisiran in 2025. So I'm just going to share this article from Dr. Fine in the diagnosis and management of ATTR, a Canadian prospective study. It says overview of the pathway for diagnosis, treatment, and monitoring ATTR amyloidosis. So treatment for ATTR should be initiated as soon as patients meet eligibility requirements for the disease-modifying therapies, either cardiac or neurological or both. And a rapid diagnosis and early treatment offer the best chance in preserving the quality of life and extending survival, particularly with the current therapies. And I'm going to focus on the end of that graph, that there are two general approaches for the treatment of ATTR: stopping the formation of amyloid or removing existing amyloids. And the current available disease-modifying treatments that we have focus on the first one, stopping the formation of the abnormal protein with the stabilizers and silencers. So what about follow-up? So there are ways to monitor disease progression in patients with cardiac amyloidosis with or without treatment, using the clinical domain, the imaging assessment, the functional domain, and also the biomarkers. And there are a few staging systems that we can use, like the Mayo Clinic, Grogan's staging table, and then the Gilmore as well. And they use biomarkers to classify the patients into stages with prognostic implications. And here are some of the examples of a follow-up assessment for patients for disease progression. That would be biomarkers and clinical assessments, and also imaging assessments. And I would like to talk a little bit on this recent published article in amyloidosis with the network history and treatment response assessed by CMR. So this study showed that ECV progression was observed in untreated patients with cardiac amyloidosis over time, while no progression was observed in patients that were treated with patisiran, and the ECV progression was independently associated with mortality. And this is another study from the same group from the UK, led by Dr. Fontana, in myocardial burden and in ATTR amyloidosis. So the aim was to define calibrated ECV thresholds to evaluate their diagnostic and prognostic value, to explore how CMR and ECV measurements could provide a quantitative framework for disease staging and also therapeutic planning. And the key advance of this work is the definition that ECV in the cardiac MRI categorized with clear diagnostic and prognostic associations, which may inform future clinical frameworks for therapeutic planning. From the risk stratification perspective, the amyloid burden as measured by ECV carried an independent prognostic information with survival declining in a graded fashion across predefined ECV values. I'm not going to go over details of this study, but this study is very interesting on the thresholds of ECV values on cardiac MRI. Thank you.
Yeah, Edgar, that was great. I think just to remind people, we'll have a question session at the end. Please do put your questions, if you do have questions for Edgar, in the chat, and we can follow up on them. We're still, we've had a slight change in our schedule, but we're hoping to continue in a minute. I don't know if Dr. Fine has access to his microphone. I don't think.
Gary?
Oh, great.
Yeah.
Great. Yes, we can hear you. A little bit faint, but I can hear you.
Okay, I'll try to speak up.
That's great. Welcome.
Sorry. Yeah, thank you. Sorry for the technical trouble. Are we going to proceed? I think Dr. Choudhury can do his case after Dr. Wall, it sounds
That's
like.
great.
So
Yeah.
should we move forward with Dr. Wall?
That'd be great. That'd be great.
Okay.
I'll leave
happy
it.
to
Yes, please.
introduce him. Yeah. So yeah, it's my great pleasure to introduce Dr. Jonathan Wall, who is a tenured and distinguished professor and also an assistant dean of research and interim dean at the University of Tennessee Health Sciences Center College of Medicine in Knoxville, Tennessee. Dr. Wall has quite an extensive list of accomplishments and accolades. Just to name a few, he helped establish the preclinical imaging laboratory to study biodistribution of amyloid reactive antibodies, including the first in human PET-CT study trial looking at the anti-amyloid body known as Cal 101. He's also the director of their amyloidosis and cancer theranostics program at the College of Medicine in Knoxville, where the focus is to develop and improve translation of biological agents for imaging and treatment of systemic amyloidosis. He's also one of the founders of Atralis, who's a company who has done remarkable advancements in imaging and developing therapeutic agents for amyloidosis. So I could list Dr. Wall's accolades for the next hour, but we want to really move on to hear him speak, of course. So welcome, Dr. Wall, and thanks for being here today.
Well, thank you for the introduction. Can you hear me and see the slides?
Yes, we can.
Okay, brilliant. Thank you. Well, I appreciate the opportunity to talk. In talking to Dr. Small before this, he wanted to hear the story of how we developed Evuzamitide in the lab. And so that'll be the focus of the talk. I have the following disclosures. And so with respect to where the story began, so in 2010, we recognized that there was a need to better diagnose and understand the biodistribution of amyloid in patients with systemic amyloidosis. And the goal was to generate something that could provide a quantitative whole body picture of the extent of the disease, including renal amyloid. I know most people on here are cardiologists, but there was a reason for that, because at that time, AL amyloidosis was the most prevalent type of amyloid, and those patients suffer from both renal and cardiac amyloidosis. And senile systemic amyloidosis, which is now ATTR wild type, was just a curiosity back then. So our goal was based on the time frame that we were working. There were, at the time, and there remain, no FDA-approved methods for the non-invasive diagnosis of systemic amyloidosis that are amyloid specific. And so there was a significant need for additional amyloid imaging agents, and that was our motivation for starting this project. So we aspired to find an agent that was capable of detecting all types of amyloid. In our lab in Knoxville, and I've been here many, many years, we studied all forms of amyloid, LEC2, lysozyme, or the rare ones, as well as AL and TTR. So we wanted something that was able to image all forms of amyloid, and it would include the heart and the kidney. We wanted it to be quantitative to allow accurate monitoring of progression and regression of disease. And we wanted it to be easily interpretable. We were working on this at the same time where they were developing the A-beta imaging agents, and there was a lot of work that needed to be done on just to interpret the images with those agents, and we wanted to avoid that. So this is a story of how it started and what we can see. So these are the two pathways for transthyretin amyloid formation and light chain amyloid formation in the bottom. And I show these not to go through them at length, but they're complex diseases, and there are lots of places for intervention in terms of therapeutics, and there are lots of things that one could image. Of course, we want to image the amyloid deposits in the organs and tissues, because as we just heard, there's a direct correlation between the amyloid burden and prognosis in these patients. And we also wanted to understand the full picture of these patients and the other organs that are involved, because we think that the impact of amyloid in other organs can also contribute to prognosis, and it will also become a major confounder or something to consider when we move into the new therapeutics designed to deplete cardiac amyloidosis. Both of these diseases result in the formation of normally folded proteins that undergo a dissociation or a misfolding event. In the case of light chains, there's a proteolytic event that probably frees up the variable domain. And in an unknown site within the body where we don't understand this process at all, there's a catalyzed misfolding of the precursor protein that's going to form the amyloid. We think that it could be done due to microenvironments on the cell membrane, interactions with heparan sulfate proteoglycans in the cell membrane. But regardless, and that's still a black box that we need to understand, misfolding occurs, concentrated misfolded protein begins to accumulate, aggregate, you get seeds, and that ultimately leads to fibrils. But amyloid is not just tissue amyloid, is not just the amyloid fibrils themselves. If you look at the amyloid proteome, there are more than 30 proteins that are associated with tissue amyloid deposits. And this list is just a short list. Everything with a double star is ubiquitously observed in all types of amyloid. Apolipoprotein E4, serum amyloid P component, and perlecan, the heparan sulfate proteoglycan. They constitute the fingerprint of amyloid when you're doing mass spec analysis of the amyloid deposits. Also important, collagen, the extracellular matrix components, but these components are accessory molecules, and some of the roles are completely unknown, but it's what makes tissue amyloid different from synthetic amyloid fibrils. This is not just a fibril just depositing. Amyloid is a complex matrix containing all these things. Serum amyloid P component, a ubiquitous component, is thought to stabilize the amyloid deposits. We've shown in the lab that the presence of collagen can impact how antibodies and macrophages see the amyloid deposits and how effective they are at actually taking up and dissolving it. And central to this discussion is the heparan sulfate proteoglycans. In amyloid, they're biochemically different from the heparan sulfate proteoglycans that you find in normal tissue. They are hypersulfated, a lot more like heparin, if you will, and their role can be quite important. They serve as a catalyst for fibril formation, at least in the lab. And with respect to AA amyloidosis, which is the amyloid associated with chronic inflammation, they are an absolute prerequisite to the deposition of AA amyloid. And so they're an important part of this story. So as I've mentioned, amyloidosis, there are about 18 to 20 systemic forms of amyloidosis. Everybody knows now transthyretin amyloidosis and AL amyloidosis. But over the years, ALEC2 from leukocyte chemotactic factor 2 has become more common. AA has become less common with the advent of anti-inflammatory agents. But there are many other types of amyloid. Most of them impact the kidneys, and almost all of them are hereditary. So they have significant familial impact on these patients. And so we're very interested in looking at all of these types of amyloid. With rare exception, almost every organ or tissue can be involved. ATTR wild type is mostly restricted to the heart, but we can see it in other tissues, obviously. But in the other forms of amyloid, you can see amyloid in the heart, liver, spleen, kidneys, nerve, lymph nodes, pancreas. And a lot of the deposition in these organs, now that we can see it, we don't understand clinically what it means. And that's something that's going to be exciting to learn about. But these are truly systemic diseases. And we think an image of the entire amyloid burden within a patient is beneficial when it comes to treatment and prognosis and talking to the patient. So amyloid in the myocardium, this is autopsy-derived material, not biopsy, but you can see on the left the immunostaining, the brown is the amyloid, and it can completely infiltrate the extracellular space around every cardiomyocyte and can be extremely extensive. And that's immunostained with anti-TTR. If you do Congo red staining and look at the red fluorescence, you can see the pattern matches beautifully. And the big picture view is that you get massive enlargement of the left ventricular wall, the interventricular septum, and the right side of the heart, causing all the problems that you guys are familiar with. So this is a major problem. And I show this slide because most people consider amyloid to look a lot like those dainty plaques in the brains of Alzheimer's patients. But this is a significant deposition of pathology. So we asked ourselves early on in the process, what's the need for detecting amyloid and amyloidosis? And I use those two words very specifically. So we came up with this sort of diagram. So there are patients who are susceptible or at risk for developing amyloid, and that could be TTR patients who bear a mutation, patients with MGUS who a certain percentage will go through to get AL amyloidosis, patients with mutations in a amyloid precursor protein that will make them susceptible to develop amyloid, or just age eventually. And we consider there to be two stages to the development of clinical amyloidosis. And the first one is the deposition of amyloid, the pathology itself. And this is the pre-symptomatic stage. And we were wondering whether we could get an imaging agent that would be able to detect pre-symptomatic amyloid before there are any reasons to go to the physician, so have an early detection system. At the time, we didn't know what we would do with that information. And when I talked to lots of people at meetings, I'm still not sure what clinically we know what to do with that information, but I think it's important to be able to see it and detect it, because a lot of those patients, most of them, or even all of them, will move into clinical amyloidosis, the disease. And imaging plays a part there, of course, in diagnosis initially, quantifying the amyloid burden, as we just saw in that great presentation, how important that is for prognosis. Whole body detection is important, particularly in the AL population, and then monitoring and looking at response to therapy. And again, a great study where you change from one stabilizer to a silencer, and the patient does well. And that monitoring and imaging can play a great role in decision-making in that case. So we set about developing some novel agents. And our hypothesis was based on a talk that I listened to at the Amyloid Symposium. And it's based on this idea that all amyloid deposits contain hypersulfated heparan sulfate proteoglycans. And that sounded to me like a good biomarker to use. They're less variable than the amyloid proteins and the fibrils that they comprise themselves. And these glycosaminoglycans are present in every amyloid. And that's why it's called amyloid, because of these glycosaminoglycans. So we reasoned, because these are very negatively charged sugar molecules, that positively charged peptides may specifically be able to accumulate in amyloid. So we went to the literature and we identified 7 very charged peptides that could bind heparin as a surrogate for the highly charged GAGs. And we had them chemically synthesized, and we assessed in a mouse model of hepatosplenic AA amyloidosis whether they could specifically bind to amyloid. And we identified one peptide that was called P5, and it was based on this data. And so this is small animal SPECT CT imaging of the 5 peptides in mice with AA amyloidosis and wild-type animals, and at 2 time points. We took imaging at 1 hour post-injection and 4 hours post-injection. And these mice have massive deposits of amyloid in the liver and spleen at the time we did imaging. And you can see from the images, P1, which is actually protamine, there is uptake in the liver and spleen. Some renal uptake here, which we didn't quite understand. This is the stomach in all these animals. This is P5, and you can't even identify the organs because there's so much uptake in the amyloid deposits in the organs in the abdomen. And when you look at the wild-type animals, which are amyloid-free, all you can see is no uptake whatsoever, apart from some radioactivity in the stomach. And so we observed this background radioactivity in the stomach very early on in our discovery phase, and it became important to understand and sort of investigate that a little bit as it pertains to how we interpret patient images. And it's all to do with the fact that we're using radioiodine as the radionuclide to do the imaging. And we assessed other radionuclides, technetium, zirconium, bromine 67 or 76 at the time, F18, but we stuck with radioiodine, and this is the rationale for it. We took advantage of the kidneys having enzymes present that strip iodide off the peptide when it's not bound to amyloid. And so as the peptide enters the kidneys, if there's amyloid there, it binds to the amyloid and doesn't get dehalogenated, whereas if there's no amyloid, the peptide is catabolized through the kidneys, the iodide stripped off, and what happens is it re-enters the circulation, and the halide receptors in the stomach wall pick up the iodide as they would chloride ions, and they make HI, which is in the stomach lumen. And that's why all the stomachs in the mice look positive, and we see the same phenomenon in people. But what this allowed us to do is to choose a time post-injection where we can image the kidneys and be sure that whatever signal we're seeing in those kidneys is associated with amyloid deposition and not catabolism of the peptide. because the peptide that's catabolized and not bound to amyloid essentially becomes invisible because the iodide's stripped off. And that's kind of demonstrated in these mice on the right. In a wild type animals, you can see blood pool at 30 minutes post-injection. That sort of weakens, and then the stomach becomes really hot because the iodide's stripped off. Whereas in a mouse with amyloid, the stomach is barely visible throughout the time course of the 2 hours that we did the imaging. So we've taken advantage of that, and this is particularly important, again, to be able to visualize renal amyloidosis in addition to all the other deposits. So we identified this peptide P5 initially, and we reasoned, well, it had 8 charges. We thought, well, if 8 is good, 12 would be better. So we developed this peptide called P5 plus 14, and that led to the imaging agents that we've developed. The first one was using iodine 124 for PET imaging, which allow us to do the quantitative, high resolution, high spatial resolution, longitudinal whole body imaging on a PET scanner. And that's since become I-124 Evuzamitide, but it also had lots of other names. And now in the last couple of years, we've developed a clinical version of a technetium labeled variant of exactly the same peptide. That doesn't have any other name other than Tech P5 plus 14 as yet. And we've just started evaluating that, and I'll show you some images about what that looks like. But we'll focus on the PET. But first, how does the peptide specifically recognize amyloid? So in addition to the heparan sulfate proteoglycans, we learnt fairly soon after that this peptide can also bind amyloid fibrils in the absence of heparan sulfate proteoglycan, because the fibrils themselves display lots of negative charge along the length of the fibril. And what happens is the peptide has no structure in solution, but when it sees a fibril or a very, very charged surface like the heparan sulfate proteoglycans, it begins to form this helix, and that helix sort of wraps up, and all the positive charges on the peptide interact with the substrate, the fibril or the heparan sulfate, and it aligns beautifully. And it's this helicity that allows specificity. If you don't have enough negative charge on the substrate, the fibril or the heparan sulfate, then you don't get multivalent electrostatic interactions. The peptide falls off, and you don't see any binding, and there's no imaging. And that's why we don't see any uptake in healthy organs, because there's just not enough charge on those tissues. In the bottom right is our model for what we think the peptide looks like on an AL fibril. It aligns along the long axis of the fibril, and the positive charges of the peptide interact with the negative charges that are expressed periodically along the long axis of the fibril, and that allows the interaction. And I don't have this image here, but all amyloid fibrils expose these negative charges along the long axis, and that's why this peptide has pan-amyloid reactivity with every type of amyloid. So we biotinylated the peptide, and we immunostained tissue with cardiac amyloid in, so cardiac tissue with amyloid in it. This is a heart from an AL patient, and you can see again characteristic binding in all the extracellular matrix in the heart, matching the Congo red birefringence, a TTR amyloid heart matching, and then we did AL kidney, and it matched as well. Again, also showing that this peptide has pan-amyloid reactivity and can react with amyloid in multiple organs. The trick was then to move into humans and actually demonstrate proof of principle and study the biodistribution and its behavior in patients with various types of amyloid and in healthy volunteers. But the first thing we wanted to do was to calculate the dosimetry, the whole body effective dose. And that means recruiting patients that you image over 48 hours and collecting images across time that you could measure washout rates and then determine the dosimetry. So I'll show you some of that data. Oh, actually, let's show the human subjects first. So this is the human subject, the healthy subjects that we enrolled, just to look at the biodistribution. And you can see there's 4 examples here. We actually image 5. This is the maximum intent, the MIPS. And as the peptide's cleared through the kidneys, the iodide's stripped off and it goes to the stomach, as you can see here. It also gets taken up by the thyroid, even though we did do iodide blocking, it wasn't complete. So there's some thyroid uptake. You do see some uptake in the parotid and salivary glands. And because of that, you see sort of bolus of saliva going down the esophagus. And so this is normal. Anyone who's imaged with hot iodide, I-131, I-124, this is the pattern of distribution of radioiodide on its own. We also could see radioactivity passing through the ureters and into the urinary bladder. And so this pattern was reminiscent in every healthy volunteer that we looked at. The stomach is really prominent, the bladder is prominent, and the glands are prominent. And this means it's very difficult using this radiotracer to detect amyloid in any of these sites, obviously. But the heart, there's no uptake whatsoever. These images were taken at 5 hours post-injection. Very little uptake at all in the liver, spleen, and the cortex of the kidneys. This is a renal pelvis with urine. And so it's a good tracer, we thought, for detecting cardiac amyloid and amyloid in other abdominothoracic organs. So the kinetic biodistribution, these are 2 patients, 2 examples. Within 25 minutes, you can see uptake in the spleen of this patient with AL and both kidneys, and that could be just normal distribution after a 25-minute injection. But what we found was that uptake was persistent throughout the 48 hours of imaging. So the kidney uptake was constant throughout the entire process. We also saw the pancreas in this patient and some small cardiac uptake, even though this patient had had a heart transplant 10 years earlier. In contrast, this is a patient with cardiac amyloidosis and pulmonary amyloidosis. The kidney and liver light up, that's blood pool value, and within 2 hours, the kidney is completely invisible. The peptide's still there, but this process of dehalogenation renders the peptide in the kidneys invisible because there's no amyloid. And so any time point after 2 or 3 hours, we can get what we consider to be a believable image of renal amyloid. And at 6 hours, you can see the myocardium lighting up here. You can also see shadows within the kidneys, and that's all that was positive in this patient. This is background in the kidney, in the stomach. And so this time point was a great differentiator between background or low signal to noise background and high. And so we chose 5 hours essentially to acquire all the images in the first in human clinical trial that we did. So then we assessed in this study pan-amyloid reactivity, and here's an example of all the types of amyloid that we imaged. This is a healthy volunteer, just to level set again, or 2. This is a patient with AL kappa, characterized by massive deposition in the liver, the spleen, positive kidneys, high uptake in the pancreas, which we don't know the clinical relevance of. An AL lambda patient with a completely different distribution, cardiac involvement, strong, with both kidneys involved. Wild-type TTR, mostly cardiac, patient with variant TTR with lung involvement and cardiac involvement. And then we also looked at ALEC2, lysozyme, gelsolin, and ApoA1. And those images demonstrated again that what we predicted in vitro was apparent in vivo, that this is a pan-amyloid imaging agent and all organs are accessible for detection of amyloid. So some more examples of looking at AL amyloidosis. This is a patient with AL that we imaged, and rather this is thresholded to show the liver and spleen, but the heart is positive. But what was remarkable here is that you can actually see the adrenal gland actually positive as well on the kidney. In this study, we had patients who were clinically documented as in the medical record as having cardiac amyloid, and we also found them to be positive by imaging. This is the clinical imaging, clinical positive, imaging positive. And there are varying degrees of amyloidosis in each of these AL patients. We also had patients who we enrolled that were clinically deemed to be negative or had no evidence of cardiac involvement, but we were able to see either fairly intense or modest deposits in these patients. Extra cardiac deposits are also visible. Again, the pancreas we've seen, the liver, lung deposits in the pleura, which are quite characteristic. The adrenal gland, which I've mentioned. In a patient with multiple myeloma and AL amyloid, we saw bone lesions that were positive for uptake. And in a patient with lymphoma and AL amyloid, we were able to see the lymph nodes in the neck associated with what we consider to be amyloid deposits in those those tissues as well. This is a patient, 48-year-old female, who came to us, long-standing AL amyloidosis, severe. She'd had severe renal insufficiency, had been on dialysis, and had a kidney transplant. She came to us for imaging, and this is one of the most extensive amyloid deposits we've ever seen in anybody, so much so that we were able to see amyloid deposits in the choroid plexus and the pituitary. Both kidneys were atrophied, the right kidney and the left kidney, both positive, but the transplanted kidney, which was remarkably negative for amyloid. So post-transplant, her light chains had been managed well, and there was no further deposition of the amyloid in that kidney, which is a remarkable study to show. We were able to see amyloid regression in a patient with AL amyloidosis who'd been on long-term daratumumab. This was the first scan. This is the patient had been on daratumumab for 12 months. We scanned him in 2019. You can see high uptake in all organs and tissues. 2 years later, the liver and spleen are markedly lower, and at 22 years later, still visually much decreased. And you can quantify that, of course, from PET. And we show a 60% reduction in liver uptake of the radiotracer and an 80% reduction in the spleen. What was remarkable was we saw a concomitant slight increase in the renal uptake of the radiotracer and no real change in the heart. This was the first realization to me, it's N equals 1, that not all the organs respond at the same rate to a therapy, to amyloid removal. And this might be an important phenomenon when we get into evaluating depleters in the clinic and what to expect in these patients. This change, particularly in the liver up amyloid load, was accompanied by a decrease in the ALK-Phos, such that this change in levels was consistent with a complete organ response. Looking at TTR patients, generally characterized by only cardiac uptake, both left ventricular wall, IVS, and right ventricular wall here. These are the healthy patients that we saw in an axial slice. You can see no uptake whatsoever in the myocardium. But looking at the clinically positive, PET positive patients with ATTR, again, extensive deposits in the left and right side of the heart. And in patients where there was no clinical evidence, we were able to get PET positive evidence of amyloid from very early deposits to very extensive deposits. We've also seen some interesting extracardiac ATTR deposits. The lung is very common and accompanies cardiac involvement a lot of the time. This is a patient with an F33I mutation. He had deposits in the adipose tissue in the neck, the pancreas, and the kidneys, as well as cardiac involvement. Joints we see quite often in the TTR patients. And in these patients, we saw subcutaneous adipose and abdominal adipose tissue uptake, as well as the heart. And in this patient, we could see actually amyloid in the spine as well. The result of our phase 1 study was basically that we had, for all subjects, a 96.2% positive agreement between the clinical diagnosis of or involvement of cardiac amyloidosis and what we were able to see. And what was interesting to me is that based on the medical record, let's go to the ATTR, 9 patients that we enrolled were not deemed to have cardiac amyloid, but we were able to see amyloid in 6 of them. We didn't see it in 3. Unfortunately, we can't put too much emphasis on this because we didn't confirm anything by endomyocardial biopsy, but it raised the flag that there may be potential to see things. We've done some correlations with some echocardiographic parameters, and we see pretty good linear correlations, significant correlations with, this is just 2 examples. This is global longitudinal strain and LV wall thickness with the amyloid radiotracer uptake based on SUV ratios. So on the horizon, what we're working on right now is a homologous pan-amyloid SPECT imaging agent using exactly the same peptide that could complement the PET Evuzamitide. We're taking advantage of technetium, the most widely used radionuclide, and the availability of gamma cameras. We've adopted a method that allows chelator-free addition of the technetium to the peptide, and we started a phase 1 single-site study in 2023. The goal is to enroll 30 patients, and we've done 20 to date. And I'll show you some quick preliminary data from that. These are the whole body scintigraphic images. On the left are 2 healthy subjects. You can see the distribution in the urinary bladder. In this case, because the technetium is not prone to the same enzymes that iodine is, both the kidneys light up at all time points. So this agent will not allow you to image renal amyloid, but there's absolutely no uptake in the healthy heart. In contrast, the ATTR patients, this is 1 hour post-injection. You can see the left side of the heart. You can actually see a free, fairly empty left ventricular lumen in these patients, really quite prominent, very different to what you see with PYP at 1 hour post-injection in a planar image. And this is a patient with AL amyloidosis where the spleen and the liver and even the salivary glands were positive, which we've never seen in TTR patients. Looking at the heart in particular, Again, the healthy volunteer, there's no uptake of the peptide in the myocardium, which you would expect. It's exactly the same peptide as we use in Evuzamitide. And the TTR variant patients and TTR wild-type patients have very prominent uptake. AL patients are the same. This is an AL patient who had myocardial uptake, and this is lesions, massive AL amyloid lesions in the lung, not just pleural sort of deposits. These are almost amyloidomas within the lung, and they were positive too. Other interesting things we've seen are tenosynovium, or we can't be specific, but this is a patient with TTR amyloidosis who'd also had carpal tunnel issues, and we were able to look at the hands with this agent and see prominent uptake in both wrists. And again, in AL patients, the salivary gland uptake, which might be diagnostic for AL relative to TTR, and is a known site for biopsy in the olden days looking for AL amyloidosis. So in summary, development of Evuzamitide has been exciting. It provides high resolution and quantitative imaging because we chose to use PET. So that allows us to get very high resolution images that allow us to see early focal deposits, as well as these large diffuse deposits that people are used to seeing. In our hands, the tracer had high sensitivity, was 96% for cardiac detection in AL and TTR patients together. It was 100% for the TTR population alone. It's allowed us to show response to therapy in a patient with AL amyloidosis. Of course, we can do whole body imaging very rapidly with PET-CT. It does have very good regulatory support, as the introduction mentioned. We formed Atralis, and it's been the company that's been taking this through to the phase 3. It was granted breakthrough therapy designation by the FDA, and the phase 3 study, the REVEAL study, completed last December, and we hope to get results from that in the first or second quarter of this year. The SPECT agent is exciting to us as well, just because it can provide widespread availability throughout the world for this type of technology. The scans look excellent. It's pan-amyloid, and it has some advantages about early imaging, even in the planar images relative to PYP. So we're excited about that. And with that, I'd like to thank the organizers for inviting me to give this talk. And this is the team in Knoxville. We've been together seems like 50 years, but it's probably more like 25 years. So I've got a great, excellent team, and we couldn't do it without the support from the NIH, the hospital, and all our collaborators, mostly in Tennessee. So with that, I thank you very much.
Thank you very much, Dr. Wall. That was great, and it's a super exciting time, really. I think just to remind people that there will be an opportunity to ask questions at the end of the presentations. But I think, seeing what's possible with imaging in terms of the distribution of the disease can, help to unpack some of the symptoms that our patients have, seeing how widespread either ATTR or AL can be in its deposition is remarkable. And then again, seeing the change over time, which you demonstrated really well. I think those are incredible things. So thank you very much for your work and for joining us today. Please put your questions in the chat. I'm going to hand back to my co-moderator, Dr. Fine, who will introduce our next presenter. No, I'm happy if you want to go on and introduce Kristen as well after Dr. Choudhury, which if you like.
Okay, yeah, sure. Thanks very much, Dr. Wall, for a fantastic presentation. I'm very happy to introduce our next speaker, who's presenting an interesting case, Dr. Rajin Choudhury. Dr. Choudhury is presently a nuclear cardiology fellow at the University Health Network in Toronto, and he is a recently graduated cardiac amyloidosis fellow at our institution here at the University of Calgary. So Rajin is going to present an interesting case. And Rajin, are you on? Share button is inactive. Okay, so.
All right, so it's active now.
It's active? Okay.
Yeah. So I'll just upload.
It's called magic.
Yeah.
IT magic.
Presenter mode. Oops. Can you see my slides?
Yes, we can.
Okay. All right. So thank you very much for giving me this opportunity to present in this amazing cardiac conference. Let me minimize. Okay. I do not have any disclosures. This patient is actually from Dr. Fine's cardiac amyloidosis clinic in Calgary. The patient is a 69-year-old gentleman from China. He had moved to Canada when he was 20 years of age. He does not smoke, drink, or use any recreational drugs. His family history is non-contributory. He did have all the few of the red flags for a cardiac amyloidosis, for the amyloidosis per se, but it all came throughout the years. His past medical history um, includes polyneuropathy and carpal tunnel syndrome, postural hypotension. He also developed coronary artery disease and had cabbage in 2022. Post-op that was complicated with acute renal failure. Um, he remained well till 2024, when again he was admitted with cholecystitis, this time complicated with shock and again acute renal failure. And cardiology was consulted because his troponins were very high. He didn't have any cardiac symptoms. However, we thought that it was type 2 MI, demand ischemia in the setting of a distributive shock physiology. He was treated with antibiotics for cholecystitis and scheduled for a cholecystectomy, laparoscopic cholecystectomy. So he was sent to us for a pre-op cardiac assessment, and that gave him an echo and an MPI. MPI did not show any ischemia. It did show some transmural infarct in the basal anterolateral wall. And other investigations showed his chronic renal failure that he was having always. The echo actually showed a small LV cavity. Um, his septum was 1.6 centimeter. Um, his LV mass was normal. Systolic function was normal at 55%. However, his global longitudinal strain was down at -13 with the apical sparing pattern. So till now, we know that he has coronary artery disease and he has LVH, and now his GLS is -12 with the apical sparing pattern. So we thought we need to investigate this further and send him for an MRI. MRI showed thickened basal inferior septum, and there was scar fibrosis, but at the areas of maximal hypertrophy, that was in basal to mid inferior septum. He had some subendocardial LGE in the inferior apical segments, and his T1 and ECB were also increased. So, given the distribution, I mean, hypertrophic cardiomyopathy of septal dominant phenotype diagnosis were favored more over infiltrative cardiomyopathy. So we sent him for a PYP scan, and obviously this came back positive with HCl ratio of 1.53 at 3 hours. And there was, in the SPECT, we can see there was uptake in the septum. So have we reached diagnosis ATTR, or didn't it rule out AL? So we sent SPEP, UPEP, protein light chain electrophoresis showed increased kappa free light chain, and the kappa lambda free light chain ratio was very much increased. So this actually led us to order for a bone marrow biopsy to rule out AL amyloidosis. We also see that his NT-proBNP was at a elevated state, always above 600, and he had this renal dysfunction, chronic renal dysfunction going on. Um, his renal dysfunction, actually, he was having low-grade albuminuria since 2022, and multiple episodes of acute renal injury. So the nephrologist, with all the amyloidosis investigations going on, warranted a kidney biopsy. And it came back positive for renal amyloidosis. Features were most consistent with arteriolnephrosclerosis, but there was a small single vessel showing amyloid within the vessel wall. But the amyloid deposits were very small for molecular characterization and subtyping. So we were again jar, uh, and hence given the clinical history of kappa restricted plasma cells in bone marrow, AL amyloid was not excluded by this biopsy. So again, we are thinking AL, MGUS. So the hematology oncologists, they sent for a full workup for myeloma and amyloidosis, and this involved also a full body PET CT, and it came back negative for any active plasmacytoma. So just a fast recap, the PYP scan was positive, and the high kappa lambda free light chain ratio. So bone marrow biopsy was sent, and then this bone marrow biopsy, uh, we were hoping to see maybe AL amyloid, but it actually stayed positive with Congo red, and hence we sent it for mass spec, and that came back as transthyretin amyloidosis and not light chain amyloid. So so it is ATTR now. Again, given the age, maybe wild type. So we sent for protein typing and amino acid sequencing, and that came back again as hereditary type ATTR with V142L mutation. Um, this is a very common mutation, predominantly found in the African descent. So now we feel that we have sorted it out and we know where we're going. But only problem was our patient was not African. He came from China when he was 20 years of age. So we looked to dig into this more into the Chinese database, and there was the China map database, which was based on cohort studies across diverse regions and ethnic groups in China. It's like the genetic database for general Chinese population, and they actually code this mutation VAL142LLE as one among the two that were classified as disease-causing variants in the Chinese population. So in summary, this patient who initially presented with postural hypotension, carpal tunnel neuropathy, recurrent acute renal failure, initially was thought to have MGUS and then light chain amyloidosis, but after the completion of all this testing, now it seemed as if he has systemic amyloidosis with transthyretin amyloidosis cardiomyopathy of the hereditary subtype as his final diagnosis. We put him on a gene silencer, and he's doing well 1 year later. Thank you very much.
Yeah, thanks very much, Rajin. Great to see you. Great case. Thanks for your presentation.
Thank you.
Like I say, we'll have a couple minutes for questions if anyone has a question about this case. The one thing I'll mention, I love this case so much because it reminds me what a humbling disease amyloidosis can be. When I first met this man, I thought he had MGUS, but did not think he had amyloidosis. After some further testing and his kidney biopsy and and bone marrow, I thought, okay, he's probably got AL, ATTR, but it's probably wild type. And then when his genetics came back positive, I thought, oh, he's going to have V50M, and it was V142I. So I was wrong at every step of this patient's evaluation. But I'm glad to say that he was very forgiving and still comes to see us and is doing very well clinically. So thanks again, Rajin. Okay, we're going to move right along now. And it's also my great pleasure to introduce Kristen Sue, who I've known for a number of years. Kristen is the Executive Director of Research at the Amyloidosis Research Consortium in the United States. where she leads initiatives to accelerate drug development and ensure that the patient voice is integrated into research and care. She's established numerous very important initiatives in her role at ARC, including the ARC FDA public-private partnership known as the Amyloidosis Forum, which brings together multiple stakeholders, regulators, clinicians, industry, to address challenges in drug development, an immensely successful model for drug development. She's been at ARC for many years and has many more years in the clinical research realm across a number of rare diseases, and has had important roles at a number of pharmaceutical companies in the past prior to this, prior to her position at ARC, including Janssen, and has a lot of experience in clinical trials. And again, I could also go on and on about Kristen, but we really want to get to her presentation as well. So Kristen, thanks very much for being here, and looking forward to your talk.
Yeah, thank you, Dr. Fine. I do feel at a slight disadvantage going after all of the amazing images for the past 3 presentations. So you'll have to bear with some of my a bit more cartoonish visuals, but appreciate the chance to speak. Are you able to see the slides in presentation mode? Okay, perfect.
Yeah.
All right. So I am delighted to be here today to speak with everyone and provide some updates on the treatment landscape for TTR cardiac amyloidosis. These are my disclosures. I'm an employee of the Amyloidosis Research Consortium, which I will describe here. The Amyloidosis Research Consortium, or ARC, is a patient-led, research-focused nonprofit organization based in the United States. Our mission is to harness the power of collaboration and innovation to advance science and improve and extend the lives of those with amyloidosis. Our model is to bring together all of the different key stakeholders across the drug development continuum to break down the barriers that slow research, with a mission to accelerate the pace of discovery, improving both the length and quality of life for patients. Since the inception of ARC, we've been keenly focused on understanding the unmet needs of patients and the barriers that stand in the way of progress. We have 4 main areas across which we work. These are the central cores of our work, and really focus around improving the speed and accuracy of diagnosis, increasing our understanding of the disease, accelerating the approval, reimbursement, and access of effective treatments for patients, and then enhancing the care and quality of life of patients and their caregivers throughout their amyloidosis journey, ultimately working to make sure they have access to the best quality information and the best quality care. And so for my presentation today, I'm going to speak from a research lens and the cross-stakeholder collaboration rather than from clinical practice, really focusing on the drugs that are being currently developed for the treatment of cardiac TTR amyloidosis. I'm sure everyone on the call is familiar, but just as a very quick reminder, when we're speaking with patients and often walking them through how we treat the disease, first starting foremost to make sure everybody has a common understanding of how TTR amyloidosis develops so that they can understand how it's treated. Everybody knows it's driven by the instability of the TTR protein. It's a liver-produced transport protein that normally circulates as a stable tetramer in TTR amyloidosis, whether variant or wild type. The tetramer destabilizes and dissociates into monomers. The monomers misfold and aggregate into amyloid fibrils that deposit in the tissue, and then where the fibrils deposit reflects the primary clinical phenotype, so whether peripheral nerves for TTR polyneuropathy or in the myocardium for TTR cardiomyopathy. Now for patients, when we describe TTR amyloidosis, using a bathtub analogy to explain disease progression and treatment strategy often can go a long ways towards helping them to understand the treatment strategy. And so in this analogy, the bathtub represents the heart, the nerves, the organs that the amyloid deposits in, and then the water dripping from the faucet represents hepatic TTR production or light chain production in AL, whichever type you're kind of focused on. And so continued production provides substrate for misfolding and amyloid formation, leading to progressive deposition in the target organs like the myocardium or the peripheral nerves. And so therapeutically, researchers can intervene at 2 key levels. So upstream, by reproducing the supply of the TTR protein. So whether that be through stabilizers or silencers that ultimately reduce the availability of the monomer from misfolding, this ultimately has shown to slow or halt new amyloid formation and may stabilize disease progression. Downstream, the hope is to address the existing burden of disease, and so that while TTR production is reduced, the pre-existing amyloid deposits ultimately remain with the current therapies. And so there continues to be a need to identify depleters or molecules that can clear the existing amyloid deposits. And so those are some of the newer strategies that are currently being investigated today. And so the novel approaches that are currently being looked at to treat TTR cardiac amyloidosis are generally designed to do one of those two things. So first and foremost, we have TTR knockdown agents, which are designed to inhibit the production of the TTR protein in the liver, thereby reducing the levels of TTR in the body, preventing amyloid from building up and depositing in organs and causing organ damage. There are three main types that are currently being developed, either have been developed or are currently in development. So you have your small interfering RNA molecules, which do this by degrading the messenger RNA that codes for the TTR protein. Vutrisiran is approved for the treatment of TTR cardiomyopathy in Canada. It's the only silencer that is currently approved for the treatment of TTR cardiomyopathy. Nucresiran, which you can see highlighted in red, is investigational and is designed, is a next generation gene silencer, small interfering RNA that is designed to allow for less frequent or biannual dosing compared to vutrisiran, which is a quarterly dosing schedule and provides deeper and faster TTR knockdown compared to vutrisiran. The next class of treatments are the antisense oligonucleotides, the ASOs. These are single-stranded molecules that work to degrade mRNA rather than cleaving it like the small interfering RNA. Eplontersen is a product. It's a ligand-conjugated antisense oligonucleotide that works in the liver to degrade TTR messenger RNA through monthly injections. This is currently in phase 3 development for TTR cardiomyopathy. And then the last of the TTR knockdown agents are is CRISPR-Cas9 molecule. So NexZ, I will not try to pronounce the full name. NexZ is what I'm going to call for the next few slides. So this is a gene editor that uses liver-directed lipid nanoparticles to deliver gene editing machinery, permanently inactivating the TTR gene in the liver, whereas our RNA silencers and antisense oligonucleotides don't act in a permanent way. And so this is currently in phase 3 development for TTR cardiac amyloidosis. The next category of drugs are your TTR stabilizers. These are your molecules that will bind to the TTR protein to prevent misfolding that leads to amyloid fibrils. Tafamidis, I think everybody is familiar with, approved in the United States for TTR cardiomyopathy in 2019. Subsequently went on to be approved in Canada for the same indication. Acoramidis is a next generation stabilizer that is designed to mimic the T119M genetic variant, offering greater stabilization than tafamidis. This is approved for the treatment of TTR cardiomyopathy in the US, though not currently in Canada. It is being developed for prevention of TTR amyloidosis, which I will speak about shortly. And then lastly, diflunisal and tolcapone are two products. Diflunisal is actually an NSAID. Tolcapone is a product that is approved for Parkinson's disease, but both have TTR stabilization properties that are being studied in different types of TTR amyloidosis. And then the last category of drugs, these are going to be the ones that drain the bathtub for the patients, are the antifibril agents. And so monoclonal antibodies designed to target and clear amyloid deposits. Coramitug and claramitug each bind to different sites on amyloid fibrils. And while both promote clearance of the fibrils through immune-mediated phagocytosis, coramitug is also designed to bind soluble non-native TTR monomers, and so it may prevent the formation of new fibrils as well. And so I'm going to talk about each of these products highlighted in red and where they are in development over the next few slides. And so hopefully by the end, everybody will have a picture of where we hope that the treatment landscape is headed for patients for TTR cardiac amyloidosis. And so I'm going to start by covering the products that are currently in clinical trials that are recruiting for patients, highlighting the study designs and where they're currently recruiting in Canada. And so I'll show this slide once more, but I'm going to start by, you can see the way this is set up. You've got your TTR stabilizers up top, shows where they are in phase of development from preclinical to commercial. I'm only going to be focusing on products that are currently have reached the clinical phase of development. So this won't include anything that's still in a preclinical phase. And so I'll start with the trials that are recruiting, starting with the TTR stabilizers, then moving to the knockdown agents, and then lastly to the antifibril agents. And we'll then look at, for the remaining products, the ones that are currently in clinical development, not currently recruiting, but have milestones coming up. We'll highlight those as well. And so I'm going to start with the 3 trials that are highlighted in red for acoramidis, nucresiran, and coramitug. So the first one we'll start with is acoramidis. Just as a reminder, this is a TTR stabilizer. It's currently approved, and so it completed phase 3 in TTR cardiomyopathy, approved in the US, where we saw that treatment with acoramidis resulted in a significantly better 4-step primary hierarchical outcome containing components of mortality, morbidity and function than placebo. It's actually now being studied to evaluate whether treatment with acoramidis can prevent or delay the development of disease in participants with confirmed but asymptomatic TTR gene carriers. And so this is the first prevention study, which is a really exciting thing to see. We would hope that treatment with acoramidis, a stabilizer, that early treatment with a stabilizer would prevent somebody from getting the disease, delaying how soon they might actually become symptomatic, either delaying it or preventing it. And so this study is going to measure time to development of TTR cardiomyopathy or polyneuropathy, whichever comes first. Cardiomyopathy will be defined by biopsy or imaging-based diagnosis, polyneuropathy by new signs or symptoms, and a biopsy-based diagnosis. It's recruiting for patients who are asymptomatic carriers of a known pathogenic TTR gene variant between the ages of 18 and 75, but most importantly, they can be no more than 10 years younger than the predicted age of disease onset based off of family history or published literature. And so it is recruiting for 582 patients. Patients will be randomized, or I should say participants will be randomized 1-to-1 to receive either acoramidis or placebo, which is given as twice daily tablets. And treatment duration is anticipated, it could be up to 7 years, depending on the number and speed at which the events accrue and patients transition into active disease as part of the study. Importantly, there is an open label extension study that is planned following this. And so those who are diagnosed with either cardiomyopathy or polyneuropathy during the course of the study will be able to go into that open label extension study and receive acoramidis for treatment of their disease. If it's polyneuropathy, if it's cardiomyopathy, they'll obviously be eligible for standard of care moving forward. This study is enrolling 582 patients across 90 different locations worldwide. There are 2 centers that are currently recruiting in Canada. I hope that my geography and representations are accurate. So University of Calgary and University of British Columbia are currently recruiting for participants in this ACT early study. Moving on to the first of the gene silencers that are currently in development. So nucresiran, again, this is the next generation gene silencer, follow on to vutrisiran. It is given as a biannual subcutaneous injection. It's currently being studied in a large phase 3 global study that will ultimately look at a primary endpoint of all-cause mortality and recurrent CV events in patients with with TTR cardiomyopathy, either wild type or hereditary. It's got a slew of secondary outcomes, again, looking at CV, all-cause mortality, recurrent CV events, and then quality of life as well as measured by the Kansas City Cardiomyopathy Questionnaire. This is recruiting for patients who have NT-proBNP levels between 300 and 8,500 nanograms per liter. If a patient is in AFib, they need to meet a slightly higher threshold for NT-proBNP. Importantly, patients can have, in order to qualify for the study, they can't have any prior or current TTR lowering therapy. So prior experience with vutrisiran or any of the, if they're outside of Canada, or have also like polyneuropathy as well. If it's somebody who has a mixed phenotype, they can't have any prior or current TTR lowering therapy experience. Stabilizer use is allowed with that said. It's a large study, 1,250 patients. Patients will be randomized 2-to-1 to receive either nucresiran or placebo. And it's estimated that everybody will be on treatment for at least 32 months, but it could take up to 5 years in order for enough events to accrue, and it will be a double-blind study during that duration. And so this is going to be, as I mentioned, recruiting 1,250 patients across 157 locations globally, highlighted here. And there's currently one center that is recruiting in London, Ontario, within Canada. So if your patients are interested in this study, it's currently recruiting in London, but there are additional centers open in the US if that's an option as well. The last of the 3 currently recruiting studies is a phase 3 study of coramitug, which is an anti-amyloid monoclonal antibody designed to prevent new TTR amyloid fibril formation and then clear the previously deposited TTR amyloid present in the heart and in the different organs. The Cleopatra study is what it's called. It builds on the phase 2 results for coramitug, which were recently shared at AHA, sorry. And so this is a study that looks at whether treatment can reduce the risk of cardiovascular death and repeated heart failure related hospital visits using a 1-to-1 randomization. There will be secondary outcome measures that look at health-related quality of life, function as well. This is a study that is requiring patients to have cardiac amyloid infiltration as well as increased left ventricular wall thickness and then chronic heart failure requiring treatment with a loop diuretic. Slightly higher NT-proBNP threshold in order to qualify. It needs to be at least 1,000 picograms per milliliter at screening. And then there can be no current or previous participation in a study for an investigational TTR depleter product or a TTR gene editing therapy. This is another large study, 1,280 patients. Patients, as I mentioned, will be randomized 1-to-1, and coramitug is given as a IV infusion every 4 weeks. And it's estimated that average treatment duration will likely be about 4 years. This study just opened within the last few months. It is currently recruiting at more than 30 of 278 planned locations across 19 different countries. There are a number of, so there's a few centers in Ontario that are currently recruiting as of now. So in Hamilton, Mississauga, I hope I pronounced that correctly, in Toronto, and then a number of different planned centers across the different provinces moving forward. And so there will be 11 total planned centers in Canada over the next few months that I expect will open. So those are the 3 trials that are currently recruiting. There are a number of trials for other therapies that are ongoing, not currently recruiting today, but are important to keep an eye on and be aware of. And so these include a phase 3 study for eplontersen, the phase 3 study for Nexz, as well as a phase 3 study for coramitug. And so I'll cover each of these briefly. Starting with the ASO, so eplontersen, it's a gene silencer that is administered subcutaneously in injections every 4 weeks. Currently approved and available for the treatment of TTR polyneuropathy and hereditary TTR, being studied in cardiomyopathy in the largest phase 3 study to date, the CardioTransform study. And so this study is completely enrolled. the piece to highlight to note is that results are expected in the second half of 2026, and so potentially some data results that will be informative of potentially future submissions and care for patients. The one piece that I would also highlight about this is that this is the biggest study to date, but it's also one that has the largest group of patients who, and a pre-planned analysis on of patients who are taking tafamidis in addition to eplontersen as part of the study. And so it'll be the first, I think, like bigger data set that we get around the potential benefit of a silencer and a stabilizer would be coming as part of this this study. And so that's something that we get asked about all the time by patients. And so will be informative, I'm sure, moving forward. The next study I'll highlight, this is actually a study that is currently on clinical hold. This is a study of NexZ or NTLA-2001. This is a CRISPR-Cas9 gene editor. It's being studied in a large phase 3 study to assess the a composite outcome of CV mortality and CV events in patients with TTR cardiomyopathy. This is in a slightly, so compared to the last study, or the Cleopatra study, this is looking at a slightly lower NT-proBNP threshold, but it's a single one-time infusion. Patients are randomized to either receive 2-to-1 to receive NexZ or placebo, with a treatment duration that we're estimating will be at least 18 months for all patients, but could be up to 4 years depending on the rate at which the events accrue within the study. This is currently on clinical hold for a regulatory review due to a protocol-defined safety incident. They had enrolled about 600 of 1,250 patients as of October, before one participant experienced grade 4 elevations in liver transaminases and elevated bilirubin, which met the study's predefined safety criteria and prompted an FDA clinical hold. There were 2 studies that were ongoing with NexZ at that time, this one in cardiomyopathy, another in polyneuropathy. The hold for the polyneuropathy study has been lifted, so that study has resumed recruiting. The company is under discussion with FDA to work through how to best reopen this trial for recruitment moving forward. And so while it's not currently recruiting, the expectation is that, you know, those conversations are ongoing, and should and when it resume recruiting, it does have 4 centers within Canada that were participating in Calgary, Vancouver, Toronto, and Montreal. And then the last study that I will highlight, the depleter CM study. So this is a study, another large phase 3 study of claramitug, which is previously known as ALXN 2220 or NI006, depending on how far you want to go back. This is another amyloid fibril depleter, so targeting the active removal of pre-existing amyloids and restoration of heart function and elasticity in adult patients with cardiomyopathy. And so this is a study that is, again, primary endpoint is looking at total occurrence of all-cause mortality and CV clinical events. They've got secondary measures looking at health-related quality of life, function, and some different analyses focusing on CV-related mortality, as well as events and all-cause mortality. This study is fully enrolled. It recruited remarkably quickly, looking at the most severe group of patients, I would say, when you're looking at NT-proBNP cutoffs. But patients were randomized 2-to-1 to receive claramitug or placebo, another IV infusion every 4 weeks. The results for this study are expected in 2027. And so there's a number of readouts anticipated over the next 12 to 18 months that are exciting, and hopefully will lead to additional treatments possibilities for patients. I will just close by quickly mentioning that as a nonprofit organization, we do offer a number of educational materials for patients. These are free to access on our website, and we have a number of booklets which can be accessed as digital booklets, or if somebody reaches out to us, we will ship them to patients directly. We can ship them to centers. This is free of charge. We provide this as a resource for patients and for centers. We also do monthly webinars. I give a talk similar to this for patients every 3 months so that patients are kept aware of the trials that are recruiting and could be available to them. Last but not least, we also offer a clinical trial finder tool called My Amyloidosis Pathfinder. So this is something that anybody can sign up for. Patients and caregivers will be asked to complete a brief questionnaire just asking what type of amyloid they have, what organs are involved, if they have experience with prior treatments, and they will be matched to clinical centers that specialize in their type of amyloidosis, as well as be informed of new clinical trials that they may be eligible for. When they sign up, they'll see any trials that are currently open and recruiting that they might be eligible for. And as we add new trials, they'll be notified in real time and provided information on how and where to contact centers if this is something that's interesting to them. So with that, thank you very much. Really appreciate the opportunity to speak to you today and hope this was helpful and informative.
Thanks so much, Kristen. It was great. I must encourage people to check out the ARC website. It really is a tremendous source for education, information from all levels, really. And Kristen's work there with them is fantastic. And as she mentioned, that these reviews they do regularly. Kristen gives them regularly. It's a real commitment to make sure physicians and patients are informed about this kind of very rapidly changing field. So thanks very, very much. Nowell, we did have an earlier question and then I'm sure you have questions. I have a few too that we can chip in. We have about 2 or 3 minutes. The question that occurred in the chat was actually for Edgar's talk, and it was really asking about the role of prealbumin in monitoring. And I didn't know if Edgar was still there. Thanks, Edgar. Do you want to just talk to perhaps the role of prealbumin and what that molecule is, and then what's its role might be in monitoring response?
So prealbumin is, or the TTR protein, is the protein responsible for ATTR cardiac amyloidosis deposits. And when it becomes unstable, then it deposits and then it causes all the diseases. So usually in ATTR, we might find lower levels of prealbumin. This is, I would say that for the diagnostic role, we don't use as a specific marker, but it helps on the role of all the results that we have to one more piece of the puzzle to tell that the patient might have ATTR. And from the treatment side, some therapies might have, especially stabilizers and the silencers, they might affect the levels of the TTR, which in patients with cardiac amyloidosis might have lower levels of the TTR, the prealbumin, and then you might have normal levels, but we don't use that as a monitoring process of the disease. It's, as I mentioned, one more tool to help assess the patient globally and then decide if we're going to use a different medication or if the medication might be effective for the treatment of that patient.
That's great. Thanks very much for that. I think just to confirm with what Edgar was saying, that the prealbumin is something that we can measure in the lab, and it reflects the tetramer form of the TTR molecule. And so it's low in patients with ATTR amyloidosis prior to treatment because they have more monomers in their circulation. They don't have the tetramers. They're not able to form that tetramer molecule. So typically on treatment, we see an increase. So the concept is that perhaps you could track that as a way of monitoring the disease. The problem is that prealbumin levels vary with other things. So on its own, it's interesting, but it would not change treatment on its own. I think we tend to measure them routinely at follow-up, and it might encourage us to monitor that patient more closely with CMR or echo or follow-up nerve conduction studies. I don't know if Nowell has any thoughts on that. Dr. Fine. Anything to add?
That's a nice summary. The only thing I'll add is, a lot of centers check it now. It's cheap and easy to check. You know, and we're still kind of looking for the magical definitions of responder versus responder to these therapies, right? Levels should go up on a stabilizer. Levels should go down on a silencer. So I think it will have a role in the future, but at the moment, there's no consensus approach about monitoring and how to respond. We need more information and data on that and clinical correlation with some of these changes.
I'm happy to keep going. I don't know if we've got, I'm waiting for Dr. Patterson to come and end our session because we're in the main lobby.
As I said, please do not hit end event though, whenever you do. That was the problem we ran into this morning. I don't know if you can see that end event button. It looks very tempting. It's nice and yellow, but do not touch it.
Okay.
So should we wrap up, Dr. Patterson? Is that
so the next session starts in 15 minutes. So there's like a 15-minute buffer.
So can we just take 2 other questions? I just
for sure. Yeah, for sure.
I don't want to put in the spot, but if you had any questions, I'm happy. But otherwise, I'll keep going. So, Kristen, can I ask you just to comment on? I think one of the things that I noticed in the trials is that in the future, I think we're going to see people on combination therapies. You touched very briefly on the kind of stabilizer silencer question that might come more clear when we look at CardioTransform. But I guess it's the other area is the kind of the depleter stabilizer. So if you give a depleter you're having that ongoing treatment, patients will still need treatment. Did you just want to mention and talk about that?
Yeah, and certainly the studies for the depleters do allow for use of standard of care. So whether that might be a stabilizer or a silencer, or quite honestly, if both would be considered standard of care. And so certainly we'll see first in the depleter study, which reads out next year. I would expect that there will be data in a subset of patients that are on either stabilizer plus depleter or the silencer plus depleter. But certainly that would be where I think combination is probably most likely. Still haven't seen like a head-to-head study of silencers against or a comparative effectiveness study, I should say, looking at the role of combination therapy versus just a single arm in TTR cardiomyloid. But certainly I can say patients are very interested in this. That's where, especially with the bathtub analogy, everybody is really looking for something that will stop the production of future amyloid as well as clear the existing deposits. Because we know that the current therapies, for the most part, are slowing progression, but patients are still dealing with the impacts of the pre-existing amyloid before they started treatment.
Thank you. Thanks very much. I just had a question for Jonathan Wall. Dr. Wall's still online, but we did have a question about imaging. I'm not sure about this, but Jonathan, do you have any data comparing your PET data with CMR? Just looking at quantification, is there anything? Do you have anything like that from the CMR, from the clinical studies on these people, and how does it correlate with like ECV measurements on CMR versus your PET uptake? Is there in the heart? Do you have anything on that?
We didn't do CMR on our patients, but Dr. Dobala at the Brigham, she has done that in her cohort where she looked at Evuzamitide, and they didn't find good correlations with ECV. And she always said, ECV is a sum of, could be many factors in addition to amyloid, and that's a complicating issue. Clearly, the amount of interstitial mass that you have impacts prognosis from the NAC paper, but whether it's actually all amyloid she is not seeing a good correlation between ECV and Evuzamitide uptake. So it's complicated. The relationship's complicated, believe it, I think.
So I think that's right. I think we're wondering if some of the ECV is not just amyloid protein, is it reactive fibrosis as well? So I think, point taken there. I think the other question I had really, and it alludes to some of our availability of using some of the silencers in Canada have relied, although that is changing, but have relied on the presence of neuropathy. And I just wondered, did you have any data on evuzamitide and nerve uptake?
So we had in our early protocol, we did image the lower limbs in the patients, the first 25 patients we recruited. One of those patients was wheelchair bound. He had the Appalachian mutation, and he had severe peripheral neuropathy. And we think, if you squinted, that you were able to see uptake of evuzamitide in the nerves. The issue is the peripheral nerves run so close to the vasculature in the lower legs that what we think is you might need a specific nerve design protocol and maybe PET MR to establish nerve uptake. And so with the minute amounts of amyloid that are in the nerves that can impact it terribly, we think you might need a longer acquisition and a different time so you get good signal to noise relative to the blood pool. So I think a nerve specific protocol would be possible, and we just haven't gone down that road yet.
Great, thank you. I'm going to hand back to Dr. Fine just to close out this session. Thanks again to all our speakers. Thanks, Dr. Fine. Thank you.
Yeah, thanks to the Ottawa Heart Institute again, and Gary and Ian for putting on this fantastic event, and I think just another fantastic workshop. And thanks for inviting me, and enjoy the rest of the conference, everyone.